Hello everyone, I'm Shoko Hara from the Institute of Science, Tokyo. I'm a vascular neurosurgeon with a strong interest in neuroradiology, and I routinely use perfusion studies in the clinical management of cerebrovascular disorders. Steno-occlusive cerebrovascular disorders include intracranial stenosis and extracranial cervical carotid artery stenosis, both of which typically originate from atherosclerosis. As you know, these conditions are common causes of stroke worldwide, both in Nigeria and in Japan. Another important disease entity is moyamoya disease and moyamoya syndrome, which cause progressive stenosis of the intracranial arteries in children and young adults. I am more familiar with sporadic moyamoya disease, which is prevalent in East Asian countries, but I believe you are more likely to encounter moyamoya syndrome with similar intracranial vascular stenosis associated with underlying conditions such as sickle cell disease. As you know, current imaging techniques such as MRA and CTA are sufficient to visualize vascular lesions. So why should we also assess hemodynamic modalities in these patients? So here's why. The patient above, who has unilateral MCA stenosis, demonstrates clear asymmetry in vascular morphology but symmetric CBF. In contrast, the patient with moyamoya disease shown below has nearly symmetric vascular stenosis, yet shows marked asymmetry in CBF. Vascular structure alone is never sufficient to understand an individual pathophysiology of each patient or their subsequent risk of stroke. So, we must always consider hemodynamic status in addition to vascular morphology. Today, I will review the modalities used to evaluate hemodynamic impairment, highlighting their advantages, limitations, and clinical significance. I will begin with the older traditional modalities, then move to more recent advanced techniques, and conclude with alternatives to direct hemodynamic measurement. So let's begin with the classic modalities that use isotopes. The PET scan using 15O is the oldest and classical criterion standard for quantifying CBF. 15O PET includes the so-called gas PET, which uses 3 inhalation tracers, and water PET, which uses an injected tracers. Both gas PET and water PET can quantify CBF, but only gas PET using inhalation tracers can measure additional important parameters, namely cerebral blood volume, oxygen extraction fraction, and the metabolic rate of oxygen. Among these, the most important parameter is OEF, an indicator of medullary perfusion, which I will explain from now. Although this is the most classical and reliable examination, it is expensive, not widely accessible, and highly invasive, requiring arterial sampling and exposure to radiation. So let's review what happens to cerebral hemodynamics in the setting of arterial stenosis. When stenosis reduces blood flow within a vessel, the first brain's response to compensate for the reduction of flow is vasodilation of the capillary vessels distal to the stenosis. As perfusion pressure begins to fall due to stenosis, this vasodilation increases cerebral blood volume and reduces vascular resistance, helping to preserve cerebral blood flow distal to the lesion. When the capillaries can no longer dilate, CBF begins to decrease. At this stage, The increased capillary volume and prolonged transit time enhance the diffusion of oxygen from the capillaries into the brain parenchyma. As a result, the oxygen extraction fraction, or the difference in oxygen content between arterial and venous blood, begins to rise. Through this compensatory mechanism, the cerebral metabolic rate of oxygen is preserved, even in the presence of reduced CVF and perfusion pressure. When the increased OEF can no longer compensate for metabolic demand, neurons begin to die. Therefore, the state of elevated OEF, known as misery perfusion, represents a condition with a high risk of neuronal injury and ischemic stroke. Previous studies have demonstrated that this theoretical risk is indeed applicable in clinical practice. These two landmark studies showed that patients with intracranial atherosclerotic stenosis and misery perfusion have a significantly higher risk of subsequent stroke compared with those without misery perfusion. Regarding moyamoya disease, our investigation and a small case series suggested that patients with ischemic moyamoya disease and misery perfusion may also have a higher risk of subsequent stroke compared with those without misery perfusion. In patients with moyamoya disease, increased OEF is also associated with postoperative complications and outcomes. This study demonstrated that patients with elevated OEF have a higher risk of hyperperfusion syndrome, a serious complication following direct revascularization surgery. At our institution, we found that the degree of increased OEF correlates with the extent of collateral development after indirect revascularization surgery. We also observed that patients with elevated preoperative OEF are more likely to experience postoperative cognitive improvement. Thus, patients with moyamoya disease and increased OEF carry a high risk of subsequent stroke and surgical complications, yet they may also derive substantial benefit from revascularization surgery. So let's move on to SPECT, another imaging modality that uses radiological isotopes. Compared with 15O PET, which is commonly used in the United States and European countries, SPECT is more widely used in Asian countries such as Japan, Korea, and China. SPECT measures the distribution of tracers within brain parenchyma after intravenous injection. Although the normal distribution of each tracer differs slightly from that of 15O, SPECT-derived CBF values correlate well with PET-measured CBF. In addition to CBF, SPECT can assess cerebrovascular reactivity, CVR, by comparing CBF before and after the administration of acetozolamide. Acetozolamide is a potent vasodilator, so CVR refers to the brain's ability to dilate capillary vessels, representing its reserve capacity to cope with hemodynamic stress. Nevertheless, as with PET, SPECT is highly invasive, costly, and not readily available as well. So let's see how CVR changes in case of arterial stenosis. As stenosis progresses and the capillary vessels become dilated at rest, CVR, or the capacity to further dilate the capillary bed, begins to decrease. Please note that CVR is not identical to OEF measured with PET. CVR starts to decline in the early phase of autoregulatory vasodilation, even while OEF remains within normal ranges. However, when both CVF and CVR are reduced, it is likely that OEF is also elevated, indicating that the brain is at the risk of neuronal injury or ischemic stroke. While CVR is not identical to OEF, studies have shown that decreased CVF and CVR measured with SPECT are also useful indicators of subsequent stroke in patients with ICAS, carotid artery stenosis, and moyamoya disease. Additionally, many studies have shown that revascularization procedures, such as direct bypass, carotid endarterectomy, or carotid artery stenting, can improve reduced CVR. Several studies, including ours, have also suggested that improvement in CVR or CVF is associated with post-operative cognitive improvement. Therefore, when decreased CVR improves after surgery, it is reasonable to expect a reduced risk of subsequent stroke, as well as potential cognitive benefits. The next topic is CT perfusion and MR perfusion, both of which use contrast agents. CT perfusion and MR perfusion, or dynamic susceptibility contrast imaging, measure contrast or signal intensity changes after an intravenous bolus injection of contrast agents. These modalities provide robust time-based parameters such as Tmax, a well-established biomarker in the field of acute ischemic stroke. These time-based parameters represent the time required for the contrast agent to reach or pass through the capillary bed. Cerebral blood volume, the volume of capillary vessels, is also theoretically reliable in both CT perfusion and DSC. However, because these contrast agents pass only through the capillaries and do not enter normal brain parenchyma, direct measurement of CBF, defined as blood flow within the parenchyma, is not possible, unlike PET or SPECT. CBF in these modalities is calculated from time-based parameters and cerebral blood volume, making it less reliable. While CT perfusion and DSC cannot quantify absolute CBF, CT and MRI are far more accessible than PET or SPECT, and these perfusion techniques can be readily implemented in daily clinical practice. Time-based parameters measured with CT perfusion and DSC change inversely with cerebral perfusion pressure. Therefore, when these time-based parameters are markedly prolonged and CBV is increased, we can infer that the region is experiencing medullary perfusion with elevated OEF. While data on CT-MR perfusion parameters and subsequent stroke risk remain limited, one study demonstrated that patients with ICAS and increased Tmax on CT perfusion may have an elevated risk of recurrent stroke compared to those without increased Tmax. Another prospective study reported that cerebral blood volume measured with CT perfusion may serve as a biomarker of subsequent stroke risk in patients with moyamoya disease receiving conservative treatment. CT perfusion is also useful for predicting post-operative complications. These two studies have shown that preoperative Tmax can predict hyperperfusion syndrome and ischemic stroke in patients with moyamoya disease undergoing direct bypass surgery. At our institution, we have used MR perfusion DSC for decades to evaluate perfusion status in patients with moyamoya disease. We have demonstrated that a preoperative increase in mean transit time predicts elevated OEF, post-EDUS ischemic stroke, and the degree of collateral development, as well as monitoring chronological changes after surgery. These findings suggest that although CT perfusion and DSC cannot directly measure CBF and OEF, they can still provide surrogate imaging markers with meaningful clinical significance. The next topic is arterial spin labeling, ASL, a non-contrast MR perfusion technique. Although CT perfusion and DSC are more accessible and easier to perform than PET or SPECT, they still require intravenous injection of contrast materials. I particularly appreciate ASL because it is completely non-invasive. Now I use CT perfusion and DSC only in selected patients, whereas I use ASL for every patient with steno-occlusive cerebrovascular disorders. ASL applies a labeling pulse to the neck and generates CBF maps without the use of contrast agents. Because it uses water molecules within arterial blood as an endogenous tracer that distributes into the brain parenchyma, its mechanism is similar to that of 15O water PET. While standard ASL can measure only CBF, a time-based parameter known as arterial transit time can be obtained by acquiring multiple ASL images at different time points after the labeling pulse. Completely non-invasive, capable of measuring both CBF and perfusion delay. It sounds ideal. However, it also has several pitfalls. In the setting of arterial stenosis, CBF values are strongly influenced by delayed arrival of labeled water molecules. For example, in this case, with a short post-labeling delay, the affected region may appear to have reduced CBF. However, with a longer post-labeling delay, the CBF no longer appears decreased as it does with a short post-labeling delay. Thus, if the post-labeling delay is too short, CBF can be underestimated in patients with arterial stenosis. In addition, signals within the arteries before they enter the brain parenchyma produce bright arterial transit artifacts. While perfusion delay leads to underestimation of CBF, these bright arterial signals can cause overestimation of CBF. CBF values obtained with ASL are complex and can sometimes be unreliable in the setting of arterial stenosis. However, when you observe decreased CBF, arterial transit artifacts, and prolonged arterial transit time, you can infer that perfusion pressure is reduced, true CBF may be decreased, and OEF may be elevated. We have found that in patients with ICAS and carotid artery stenosis, CBF values obtained with ASL correlate well with true CBF measured by 15O PET. The underestimation of CBF caused by perfusion delay was offset by the overestimation from arterial transit artifacts, resulting in a moderate correlation. We also found that the coefficient of variation, ASL-CoV, is useful for detecting hemodynamic impairment. In case of arterial stenosis, the mean value decreases by perfusion delay, and heterogeneity of ASL signals or standard deviation within the region of interest increase as the mixture of bright voxels and dark voxels. These changes ultimately lead to the increase in ASL-CoV. This ASL-CoV, although not perfect, indicates whether patient had decreased CVR on SPECT in patients with ICAS and carotid artery stenosis. One study has even shown that arterial transit artifacts alone can help distinguish whether patients with carotid artery stenosis are symptomatic or not. In patients with moyamoya disease, arterial transit time is much longer than in those with atherosclerosis, and arterial transit artifacts are much more prominent. Nevertheless, CVF measured by ASL with a standard post-labeling delay still shows a moderate correlation with true CVF measured by 15-NO-PET. In addition, ASL-CoV, the heterogeneity of ASL signals within the region of interest, can potentially detect increased OEF. We have found that even a simple visual scaling system, without placing region of interest or calculating mean values or CoV, is useful for identifying increased OEF. Some studies have also demonstrated that more advanced ASL techniques can provide a more accurate assessment of hemodynamic status, but I will not go into that topic today. The key point is that even with standard ASL acquisition, you can still understand the hemodynamic status of each patient, although not perfect. ASL is also useful for detecting chronological changes in perfusion after revascularization surgery or during follow-up. Our studies, as well as those from other groups, have shown that ASL can detect post-operative improvement in perfusion or clinical deterioration during conservative follow-up. ASL is also helpful for predicting post-operative complications such as hyperperfusion syndrome after direct bypass surgery. Because ASL is completely non-invasive, requiring no contrast agents and no radiation exposure, and can be acquired together with routine MRI, it is an excellent modality, especially for children, pregnant women, and essentially all patients. If you need absolute CVF values comparable to those obtained with PET or SPECT, ASL is not a perfect method. However, it remains useful at every stage, from determining surgical indications to post-operative management and long-term follow-up. The last topic is alternative methods for direct measurement of cerebral hemodynamics. As you know, time-of-flight MRA is the standard technique for assessing vascular structures in daily clinical practice. However, MRA does not represent the true anatomical structure. Because time-of-flight MRA relies on the inflow of unsaturated water molecules into the imaging slices, its signal intensity is strongly influenced by the flow velocity within the arteries. In other words, the signal intensity of each vessel provides an indirect estimate of intracranial arterial flow velocity. Please remember that the flow velocity inferred from the signal intensity of time-of-flight MRA is not equivalent to any traditional hemodynamic parameters obtained with dedicated hemodynamic modalities. However, decreased signal intensity in distal arteries may suggest reduced CVF, impaired CVR, or increased OEF, miliary perfusion. Several studies have shown that the signal intensity of distal cerebral arteries on time-of-flight MRA is useful for detecting decreased CVF, CVR on SPECT, in patients with ICAS and carotid artery stenosis. Therefore, even when standard hemodynamic modalities are not available, time-of-flight MRA can provide indirect information about the patient's hemodynamic hemodynamic status. A similar approach also works to predict postoperative complications. These two studies have shown that patients with decreased signal intensity in distal vessels are at higher risk of developing hyperperfusion syndrome in both moyamoya disease and carotid artery stenosis. Again, time-of-flight MRA is not the direct measurement of hemodynamic status and cannot fully replace standard hemodynamic modalities. However, it remains useful for identifying patients who may require additional hemodynamic evaluation, especially when access to dedicated hemodynamic studies is limited. The last topic is the flare IV sign observed in patients with moyamoya disease and moyamoya syndrome. The IV sign is an MRI finding characterized by high signal intensities along the cortical sulci and subarachnoid spaces, resembling IV creeping over stone. The original IV sign was described on gadolinium-enhanced T1-weighted imaging and is believed to represent dilated leptomeningeal collaterals on the cortical surface. In 1999, a Japanese neuroradiologist reported that a similar appearance can also be seen on FLAIR and should not be mistaken for subarachnoid hemorrhage. The FLAIR IV sign is thought to reflect slow flow within dilate cortical vessels that fail to produce normal flow voids. A similar finding can be observed in patients with acute ischemic stroke due to large artery occlusion, where it is referred to as the hyperintense vessel sign. The FLAIR IV sign is, again, not identical to any traditional hemodynamic parameters. However, when the IV sign is present, it suggests that the presence of dilated capillaries, increased blood volume, and prolonged transit time. Many studies have shown that the FLAIR IV sign in moyamoya disease or syndrome correlates well with preoperative and postoperative hemodynamic parameters such as CBF and CVR measured with SPECT. Moreover, one study demonstrated that pediatric patients who show no improvement in IV signs after revascularization surgery have a higher risk of stroke during follow-up compared with those who do not show improvement. These findings suggest that, although the FLAIR IV sign is not identical to traditional hemodynamic modalities, it can still provide useful insight into a patient's hemodynamic status. Like time-of-flight MRA, FLAIR is a routine clinical sequence that requires no contrast agents and no additional scanning time. Inferring hemodynamic status from these routine sequences is particularly beneficial for children who require minimum scanning time and for institutions with limited access to traditional hemodynamic modalities. In conclusion, multimodal imaging of cerebral hemodynamic disturbances can inform stroke risk, surgical indications, postoperative complications, and surgical outcomes in steno-occlusive cerebral vascular disorders. A solid understanding of the strengths and limitations of each modality, including alternative approaches, will help neuroradiologists better understand pathophysiology and make appropriate treatment decisions for each patient. Thank you for your attention, and I will welcome any questions or comments.